Welcome to our deep dive into the world of ruptured abdominal aortic aneurysms, or RAA for short. We've got some fascinating medical research and journal articles lined up today.
RAAA is, it's not exactly a dinner table topic, but it's a condition that more people should be aware of.
Absolutely. Today our mission is to equip you with the key knowledge about RAAA, from what it is to how it's treated, and even what the outcomes might be. We're really going to break it all down.
Yeah, and you might be surprised to learn that even with all the medical advances we've made, the mortality rate for folks who make it to the hospital with a ruptured AAA is still around 50%.
50%?
Yeah.
That's a scary statistic. And even scarier, 40% don't even make it to the hospital. So
Yeah.
clearly this is something serious. So let's start at the beginning. What exactly is a ruptured abdominal aortic aneurysm?
Well, to understand that, we've got to start with the aorta itself. It's the biggest blood vessel in your body, running from your heart all the way down through your chest and abdomen. An aneurysm happens when a section of the aorta weakens and starts to bulge outward, kind of like a balloon.
So like a weak spot on a tire that starts to bubble out.
Exactly, you got it.
Okay. So not every aneurysm will rupture though, right? Some might just cause symptoms like pain.
You're right. With a ruptured AAA, though, that bulge bursts open, and that leads to massive internal bleeding.
That sounds terrifying. No wonder the mortality rate is so high. So who's most at risk for this?
Well, age is definitely a factor. People over 60, and especially those over 80, are at a much higher risk.
And men are more likely to have an AAA than women.
Yes, it's a lot more common in men. Also, if you have a close relative who's had an AAA, your risk goes up.
What about smoking? That's got to be a factor, right? Like with most heart issues.
Absolutely. Smoking damages blood vessels, which makes them more likely to weaken and bulge.
Okay, so we've got age, family history, and smoking. Those are all, pretty common risk factors for lots of health problems. I remember reading that race used to be considered a risk factor, but that's been reevaluated, hasn't it?
You're right. There was an association, but the thinking has changed. What we understand now is that any link between race and AAA risk is probably more about differences in access to healthcare, screening, and treatment than anything else.
So it's more about healthcare inequality than like an inherent predisposition based on race.
Exactly.
Interesting. And this actually leads to another question. Women might be underdiagnosed with AAAs just because their aortas are usually smaller. Is that right?
That's true. Smaller aortas can make the aneurysm harder to detect, so women might be slipping through the cracks, so to speak.
So the tools used to diagnose AAAs might not be as sensitive for women. Let's talk about diagnosis. How is an AAA actually diagnosed?
Well, sometimes a doctor can feel a pulsatile mass during a physical exam. It's a kind of throbbing sensation caused by blood flowing through the enlarged aorta.
But I mean, wouldn't it be easy to miss that, especially depending on, someone's body size?
You're exactly right. It's not always that reliable. That's why a lot of emergency departments are turning to point-of-care ultrasound or POTUS.
Huh.
Yeah. It's basically a portable ultrasound machine that can be used right there at the bedside. It can show very quickly whether an aneurysm is present or not.
So it's pretty accurate.
Very. Some studies have found POCUS to have 98% sensitivity and 99% specificity for diagnosing AAAs.
Wow. So a quick ultrasound can pretty much tell a doctor whether there's an aneurysm or not. What happens after that?
Well, sometimes other imaging techniques are used to confirm the diagnosis and help plan for surgery, like CT scans or MRIs, but POCUS is usually that critical first step.
So, when we were preparing for this deep dive, I learned something fascinating. The first successful surgery for a ruptured AAA used material from a parachute.
It's true. Back in 1951, a surgeon named Dr. Arthur Voorhees used a Vinion end graft, the same material used in parachutes, to do the first successful open repair of an AAA.
Parachute material in an artery. That's amazing. I'm sure surgical techniques and materials have come a long way since then.
Oh, absolutely.
So what are the treatment options today for someone with a ruptured AAA?
Well, before we get into the specifics of the procedures, the first thing to understand is that there's something called a selective treatment policy in place.
Selective treatment. What does that mean?
It basically means doctors have to make some very difficult decisions about which patients are most likely to actually survive surgery. Sadly, sometimes folks arrive at the hospital in such critical condition that surgery just isn't likely to work.
That must be a heart-wrenching decision for everyone involved. So how do they decide who's a candidate for treatment?
There are scoring systems that help assess risk. These systems look at things like the patient's age, their blood pressure, how well their kidneys are working, and whether they went into cardiac arrest before getting to the hospital.
So it's not a simple decision. It's not just, oh, there's an aneurysm, let's operate.
No, not at all. They have to weigh the potential benefits of surgery against the very real risks.
So for someone who is considered a candidate for surgery, what are the procedures?
There are two main options: open surgical repair, or OSR, and endovascular aneurysm repair, which is also called EVAR.
OSR and EVAR.
Yep.
Okay, let's break those down. What's involved with open surgical repair?
Well, OSR is definitely the more invasive of the two. It involves a large incision in the abdomen to access the aorta and replace the weakened section with a graft.
And EVAR. That sounds like it might be less intense.
Yeah, EVAR is less invasive. A catheter is inserted into an artery, usually in the groin, and guided up to the aneurysm. Then a stent graft is placed to reinforce that weak area. It's essentially creating a new lining within the aorta.
So it's kind of like building a little internal scaffold to support the aorta.
Exactly, you got it.
That makes sense.
Yeah.
But can everyone have EVAR?
Unfortunately, no. EVAR is only an option if the aneurysm is the right shape and in the right place.
So there's no one-size-fits-all solution. How do doctors decide between open surgery and EVAR? Is there one that generally has better outcomes?
Well, that's where things get tricky. The research can be a bit conflicting. While EVAR often has a lower mortality rate in the period right after surgery, the long-term data isn't always clear.
So even though EVAR is less invasive, it's not always the clear winner.
Right. And it also depends on the expertise of the surgical team, which brings us to the concept of centralization.
Right, the idea of sending patients with ruptured AAAs to specialized centers, not just the nearest hospital.
Hmm.
That makes a lot of sense, right? Having those specialized teams and resources available.
Does. And studies have shown that centralization is linked to lower mortality rates, fewer complications, and even shorter hospital stays.
But I imagine there are some challenges to this. What about people who live far away from these specialized centers? When time is of the essence, wouldn't that delay be a huge problem?
Absolutely. It's a balancing act, trying to ensure everyone gets timely care regardless of where they live, while also making sure they have access to the best possible treatment. It's a tough problem with no easy answers.
This is a lot to consider already, and we're just getting started. Stay with us. We'll be back after the break to talk more about the evolution of treatment and outcomes. We were just talking about how, choosing between open surgery and EVAR for a ruptured AAA isn't always so straightforward. Even though EVAR is less invasive, it sounds like the long-term data is kind of fuzzy.
Yeah, that's right. I mean, a lot of studies do show that EVAR has a lower risk of dying right after surgery. But when you look at long-term outcomes, things get a little less clear. There are even studies that suggest open surgery might be better for certain patients in the long run.
So basically what you're saying is even though less invasive sounds great, the best option really depends on my individual situation, right? What might be best for me might be different for someone else.
Exactly. Plus, as we mentioned before, the skill of the surgical team is a big factor, which kind of brings us back to the idea of centralization.
Right. Sending patients with ruptured AAAs to specialized centers instead of just the nearest hospital. It makes sense that having specialized teams and procedures and all those resources would lead to better outcomes.
Oh, absolutely. Studies have actually shown that centralization is linked to, lower mortality rates, fewer complications, and even shorter hospital stays.
But I'm guessing there are some challenges with centralization, right? Like, what about folks who live far away from these specialized centers? When every minute counts, wouldn't that extra travel time be a major issue?
It's definitely a tough situation. There's that constant tension, right? Getting patients to these highly skilled surgeons while also making sure everyone gets care quickly no matter where they live. It's a tricky problem.
It sounds like there are so many pieces of the puzzle when it comes to treating ruptured AAAs. It's not just the surgery itself, but the whole system of care surrounding the patient.
Yeah, you got it. And this whole system is constantly evolving too. We're seeing a lot of progress not only in surgical techniques, but also in how doctors assess risk before surgery and how they manage care afterwards.
Let's talk more about that pre-op risk assessment. You mentioned scoring systems before. How do those work? What kind of things do they look at?
Well, these scoring systems, they're basically designed to predict how likely someone is to survive after surgery for a ruptured AAA. They take into account a bunch of factors like your age, blood pressure, kidney function, and whether you had a cardiac arrest before you got to the hospital.
So it's like a personalized risk calculator to help doctors determine the best course of action.
That's a good way to put it. But it's important to remember that these scores aren't perfect, right? They're not crystal balls.
So a high-risk score doesn't automatically mean someone won't get surgery.
That's right. It's always a judgment call based on each individual's circumstances and overall health. These scores just provide helpful data, but they don't tell the whole story.
So if those scores aren't foolproof, how do doctors ultimately decide who gets treatment and who doesn't? That seems like an incredibly difficult position to be in.
It really is. It's one of the toughest things about emergency medicine, especially with a condition like this that's so serious and so time sensitive.
It sounds like it comes down to very carefully weighing the potential benefits of surgery against the potential risks,
Yeah.
especially if the patient is already very sick.
Exactly. And these decisions, they're made after discussions with the patient, if possible, and their family. Their wishes and values are part of that conversation, too.
Okay, so we've talked about how ruptured AAAs are diagnosed, the different surgical options, and how doctors decide who's a candidate for surgery. What happens after surgery? What can someone expect if they have surgery for a ruptured AAA?
Well, as we've discussed, even with all the amazing advancements in medical care, the risk of dying from a ruptured AAA is still significant. But survival isn't the only thing we need to think about, right? Quality of life after surgery is important too.
And I imagine that can vary a lot from person to person, depending on the severity of the rupture, any other health issues they have, and just how well they recover overall.
It absolutely does. And there can be complications after such a major surgery. Bleeding, infection, kidney problems, even heart issues can happen. Recovery is different for everyone. Some people bounce back fairly quickly while others have a tougher road ahead.
So there's no typical recovery timeline.
Not really, no. It's very individualized. Often, physical therapy, cardiac rehab, and ongoing medical management all become part of that long-term recovery.
It sounds like having a ruptured AAA can have a really lasting impact on your life, even if you survive the initial rupture and surgery.
Yes, and that just underscores how important it is to not only focus on that initial crisis, but also provide support and care throughout the whole recovery journey.
We've learned so much about ruptured AAAs today, but I'm wondering, are there any promising new developments on the horizon for treatment? What does the future look like?
That's a great question. And it's a really exciting time to be in this field. Researchers are constantly working to find ways to improve outcomes.
Mhm.
We're seeing fantastic advancements in imaging technology, the development of even less invasive surgical techniques, and a growing focus on personalized medicine.
That all sounds very encouraging. What are researchers most excited about right now?
One area that holds huge potential is artificial intelligence, AI.
AI,
Yeah.
like something out of a sci-fi movie. How could that be used to treat ruptured AAAs?
It might sound futuristic, but AI is already making its way into medicine. In the context of ruptured AAAs, AI can help analyze tons of patient data to identify subtle patterns that humans might miss. This could help doctors figure out which patients would benefit most from specific treatments.
So it's like AI could help make treatment plans even more personalized.
Exactly. And on the surgical side, there's a lot of interest in developing even less invasive techniques to shorten recovery time and minimize complications. Some surgeons are even exploring robotic-assisted surgery for ruptured AAA repair, which allows for greater precision and control during the procedure.
Robotic surgery. It's amazing how rapidly things are advancing in this field.
It really is. And all of these advancements, they're all focused on one thing: improving survival rates, reducing complications, and just making life better for people affected by this serious condition.
It definitely gives me hope knowing that even though ruptured AAAs are very dangerous, the future of treatment is looking brighter.
I agree. We're making great progress, and the dedication of the researchers and clinicians in this field is truly remarkable.
This deep dive has been so informative. As we wrap up, let's make sure we highlight the key things our listeners should take away from all this. What do you think are the most important points to remember?
Well, the most important thing is to understand the risk factors for AAA. If you're over 60, if you're a man, have a family history of AAA, or if you smoke, it's really important to talk to your doctor about getting screened.
Early detection is so key, right? The earlier an AAA is found, the more options you have, and the better your chances of preventing a rupture in the first place.
Exactly. And if you experience any symptoms that could point to a ruptured AAA, don't wait. Get medical help immediately.
Call 911 or get to the hospital as fast as you can. Every second counts in these situations.
Absolutely. The faster you can get treatment, the better your chances of survival. And remember, it's okay to ask for help. There are amazing medical professionals out there who are ready to support you through this.
And we also talked about how the decision between open surgery and EVRA is very individualized. There's no one right answer for everyone.
Yeah, it's a really complex decision, and it should always involve a conversation with your doctor. They can help you weigh the pros and cons of each approach based on your specific situation.
This deep dive has really highlighted for me how medicine is as much an art as it is a science. It's not just about following protocols, but about really understanding each person's unique needs and making difficult decisions with compassion and careful judgment.
I couldn't agree more. That open communication between the patient, their families, and the medical team is so important in these situations. It helps ensure that the treatment plan aligns with the patient's goals and values.
As with any good deep dive, we've learned so much today, but it's also left me with even more questions.
That's the great thing about knowledge, right? It often sparks more curiosity.
Exactly. So as we wrap things up, I want to leave our listeners with one final thought to ponder. We touched on this idea of selective treatment for ruptured AAAs, where doctors have to make incredibly tough choices about who's most likely to benefit from surgery. It really makes you think. How do we balance individual patient autonomy with the responsible use of limited resources, especially in these urgent situations?
It's a huge question with no easy answers, but it's a vital conversation to have.
Well said. And on that note, we'll conclude our deep dive into the world of ruptured abdominal aortic aneurysms. We hope you found this exploration insightful and maybe even a little inspiring. Remember, knowledge is power. The more you understand your health, the better prepared you'll be to make informed decisions about your care.
Thanks for joining us on this journey of discovery. Until next time, stay curious and keep learning.
Welcome back to our deep dive into ruptured abdominal aortic aneurysms. We've learned a lot about what they are, how they're diagnosed, and the treatment options, along with all the complexities that come with this condition.
It's been a pretty in-depth look, for
Mhm.
sure. But before we finish up, I think it would be helpful to, just go over some of the key takeaways for our listeners.
Definitely. What are the most important things you think people should remember from all this?
Well, first of all, it's so important to understand the risk factors. If you're over 60, a man, have a family history of AAAs, or if you smoke, it's really important to talk to your doctor about getting screened.
Screening can make a huge difference, right? Finding a AAA early means you've got more options and a better chance of avoiding a rupture in the first place.
Exactly. And if you have any symptoms that might mean a ruptured AAA, don't wait. Call 911 right away. Get help immediately.
Time is critical. Don't hesitate. Just get to the hospital as quickly as possible.
The faster you get treatment, the better your chances are. And remember, asking for help is a sign of strength, not weakness. There are incredible medical professionals out there who are ready to help. They want to help.
We also talked about how deciding between open surgery and EVR is a really personal decision. What's best for one person might not be best for another. There's no single right answer for everyone.
Yeah, it's a complex decision that should always involve a conversation with your doctor. They can help you weigh those risks and benefits of each approach and find what's best for you.
I think this deep dive has really shown me how medicine is like both an art and a science. It's not just about following rules and protocols, but also about understanding each person's unique needs and making these tough decisions with compassion.
Absolutely. And it's so important to have that open communication, between the patient, their family, and the medical team. That way everyone's on the same page and the treatment plan really aligns with the patient's goals and values.
We've learned a lot in this deep dive, but as usual, it's left me with more questions too. Seems like the more we learn, the more we realize how much more there is to discover.
It's true. Knowledge often leads to more questions. It makes you want to keep digging deeper.
So to wrap things up, I'd like to leave our listeners with a final thought. We talked about selective treatment for ruptured AAAs, where doctors have to make incredibly tough decisions about who would benefit most from surgery. It really makes you think, how do we balance individual patient autonomy with, the wise use of limited resources in those high-pressure emergency situations?
That's a really important question, and there are no easy answers, but it's a conversation we need to keep having.
Definitely. And on that note, we'll bring our deep dive into the world of ruptured abdominal aortic aneurysms to a close. I hope you found it informative and helpful. Remember, knowledge is power. The more you know about your health, the better equipped you'll be to make informed decisions about your own care.
Thanks for joining us today. Until next time, stay curious and keep learning.